In general terms, melanomas that are 1 millimetre thick or more are considered for sentinel node biopsy. Sometimes there are situations in thinner melanomas, very early melanomas, less than 1 millimetre thick, we will still consider doing sentinel, or at least offering sentinel node biopsy for those patients, because there are aspects of the primary skin lesion that guide us to whether or not this is a well-behaving condition or potentially a bad behaving melanoma. So there are several parameters in the analysis of the skin primary that we will have access to prior to the operation to allow us to plan this. So we're looking predominantly at how thick it is. Certainly if it's 1 millimetre thick, you've got our interest in offering that. Thinner lesions that are ulcerated have got our attention and will generally see us offering sentinel node biopsy. Sometimes we'll see lesions that have what we call a high mitotic rate, that is cellular division, telling us this is a rapidly biologically growing entity here. That will attract our attention too. Some things equally will steer us away from sentinel node biopsy because we know it requires a general anaesthetic. So when patients are fairly elderly or they've got lots of other medical problems, we won't be wanting to expose them to any risks related to general anaesthesia, because we're only trying to make this work out better, not just to blanket expose this procedure to all. By and large, when melanomas hit a thickness of 1 millimetre, we're very interested in at least considering and talking to that patient about having sentinel node biopsy in addition to widely excising their primary lesion.